This panel discussion will focus on the state issue. We're going to look at what does the Affordable Care Act look for our state. We heard the national panel, and now we're going to hear from our state experts. Our panel will be moderated by Representative Will Davis, who represents the Illinois 30th District. But having worked with him in Springfield, he represents the whole state of Illinois and does a good job working on issues that affect everyone in the state of Illinois, not just his district. He serves on several committees. One of them, I'm going to list a couple of them. All the bios are in here in your packet as well. He's the chairman of both the Appropriations, Elementary and Secondary Education, and the Special Committee on Health and Healthcare Disparities. He also serves as a member of the Appropriations, Higher Education, International Trade and Commerce, Labor, and Mass Transit. He's a very busy man. He also serves as a joint chairman of the Illinois Legislative Back Caucus. I'd like you to join me in welcoming our moderator and the rest of our experts on the panel.
Good afternoon, everyone. Oh boy, was that break too much for you? Good afternoon, everyone.
Good afternoon.
Thank you very much. I just have one correction. I am no longer the chair of the Black Caucus. I relinquished that after 4 years of serving in that capacity. The joint chair of the caucus now is Representative Ken Duncan, so if anybody's looking for somebody to bug, there he is, right there, right there. I want to thank Jim Duffin and the Campaign for Better Healthcare for allowing me the opportunity to be here with you this afternoon. And as I was just listening to some of the presentations and awards, I was thinking a year ago I sat as a panelist. Now I'm a moderator. Maybe next year I'll become Sarah Feigenholtz or something, something like that. Hi, Sarah. How you doing? So no, it is indeed an honor to be here with you, and I'm proud to have the opportunity to moderate this panel where we're hoping to dive into some of the questions that I believe some of you have submitted with regard to the state of Illinois and their participation in the state exchange. I have a very distinguished group of panelists here. What I'd like to do is give them a minute or so to introduce themselves, their organizations that they're with, and then we'll dive right into the questions. So let me just start to my immediate left here, to my former colleague, former State Senator A.J. Wilhelmy.
Thank you, Representative Davis, and good morning or good afternoon to everyone. My name is A.J. Wilhelmy. I'm the Chief Government Relations Officer for the Illinois Hospital Association, and I just want to first of all say to everyone at the campaign, congratulations on embarking on your 25th anniversary. It's really been an honor and a pleasure in my almost 2 years at the association to work closely with you as a partner. And really, the work that you do is so meaningful, so important. Everyone in, nobody out. We need to continue to fight for healthcare justice, and I know that's your mission, and I look forward to working with you as we move forward in these very challenging times in healthcare and health delivery. I don't know, Jim, if you want us to go through our remarks now. Okay, and then I'll pass it on to the folks to my left. And I'll be brief because I know we do have a number of questions we want to get to. But I also want to say thank you to Representative Will Davis and thank you to Leader Sarah Feigenholtz. When we think about state policy in healthcare, we know that the challenges are enormous. But these are two individuals that are committed to making sure that the state is on the right path. And that's something that we're committed to at the Illinois Hospital Association. Our leadership, our Board of Trustees, and Dr. Raju, who just left, just received an award, is on our Board of Trustees. We are committed to making sure that we fulfill the vision that was established by our board in 2011. And it's very short, and I want to read it to you because it really is indicative of the work that we're engaged in at the association. And I think you'll appreciate the progressiveness of this vision statement. All individuals and communities deserve access to high-quality health care at the right time and in the right setting to support each person's quest for optimum health. All people and all communities deserve that, and we're committed to that. And so when we talk about the Affordable Care Act, the American Hospital Association, the Illinois Hospital Association supported the ACA back in 2010, before I was at the association, and we continue to support it. And that's because we've long held the belief that coverage and access is very important. It's paramount as we move forward with health reform. And achieving the triple aim of improving quality, lowering costs, as Ron Pollack talked about, and really enhancing and improving the health of all people in this state and focusing on population health. So when we talk about this, we want to make it real. Now, we have a board that's very progressive. We have a Transforming Illinois Healthcare Task Force that came up with a 4-page document that really laid out our vision, our principles, access and coverage, the triple aim, but really more specifically got into objectives, goals, and pathways. And I just want to mention a couple of those. Number one, enhancing the care and safety net communities. That's very important to our board and to our association. Number two, making sure that we coordinated comprehensive service delivery. And I want to talk about that in terms of how we go forward with health reform and health initiatives. And then number three, want to make sure that you know that preserving access and coverage is very important. And when we talk about that, two big issues from the ACA, Medicaid expansion, and I want to congratulate Leader Feigenholtz. Leader Feigenholtz was in the trenches, along with Senator Staines. And many of us in the room were with you in that journey. And we got it done collectively, but it wouldn't have happened without the leadership of Sarah Feigenholtz and Heather Staines and Governor Pat Quinn. So thank you for making Medicaid expansion a reality in Illinois. The other ACA implementation issue at the state level is, of course, the state-based health insurance marketplace or exchange. That has not moved forward. We at the association, like you at the campaign, and many of us in the room, believe that a state-based exchange is the right way to move forward. It's better to bring that more closely to home so you can control what that exchange and that marketplace looks like. And obviously states that have done that, like California, have seen much better success than what we've seen given all the glitches at the federal level. And that's not a criticism, that's just a reality. So we continue to move forward in that direction so long as there's an adequate network through that exchange and we have a voice at the table along with all of you, and that the funding is done by those who should be at the table funding that. But I want to talk real quickly about care coordination, which is central to the ACA, which is central to health reform, and which is central to achieving the triple aim. And I want to just reflect very briefly on our document, which is our pathway to transformation. That's what we're calling it. It's our framework as we work with policymakers and other stakeholders. Here are the key issues in terms of the pathways that we have established at IHA to make care coordination real. Invest in healthcare innovations. Talk about that in a moment. Facilitate coordination among all providers, of course, but here are some specifics that we've articulated in our document. Developing patient-centered medical homes, integrating behavioral health services, providing community-based alternatives to institutional settings, ensuring provider and consumer protections as the state moves forward with managed care. Those are key to making sure we do care coordination right. Now, under the Medicaid expansion bill, Senate Bill 26, the legislature, in their wisdom, signed by the governor, created an opportunity for us to do provider-sponsored care coordination. We believe in care coordination at the association. We believe that it should be done by providers and led by providers. We have the technology, we have the equipment, we have the capabilities and the competencies. We have relationships in our hospitals and systems with our patients, with physicians, with nurses, and we are best equipped to actually do the hard work of care coordination, and it is difficult. So we're very happy that there are accountable care entities now, codified in state statute under Senate Bill 26, to allow providers in partnership with FQHCs, with community-based organizations, with physicians, and many others, to create the network to make sure that patients are getting the best care possible, good quality, good outcomes, lower cost, by doing this very difficult work of care coordination. And let me just add one more thing before I pass it on. All of this work is very important. It has to happen for us to have meaningful health reform. But let's not be mistaken. It is tremendously difficult. This is big change. It is very difficult work. And it takes resources and capabilities in order to make it real. It's one thing to talk about care coordination. It's another to do it. And we have a state with tremendous challenges. And let's just look at a couple of them. We are 50th in the country in our Medicaid per beneficiary spending in Illinois. That is very challenging. We cannot see any further cuts to Medicaid. We've already seen cuts, and I understand it was a difficult process. I was there at the table in 2012. But $380 million in Medicaid cuts in Illinois in the last few years. $11 billion in federal Medicare cuts over the last few years, just to hospitals. That doesn't cover other providers. And we have about 40% of our hospitals that are currently operating in the red today. And so we have great challenges. And what we know is that we need to be creative. And we need to access resources where there are resources available. 15 or so other states have pursued an 1115 Medicaid demonstration waiver to help bring in federal support, federal financial support, to get these innovations and this transformation work off the ground. And so we applaud the state. The governor's made a commitment to doing a Medicaid 1115 demonstration waiver. It's under Section 1115 of the Social Security Act. It gives states flexibilities to invest in these innovations, to do the transformation, whether it's through creation of integrated delivery systems, whether it's through creation of medical homes, by doing more care coordination and especially integrating behavioral health with our medical health services that we provide. If we can get this designed right, if the state does the design right on an 1115 Medicaid waiver, we could see significant federal resources come into this state to help us with this very difficult work. None of us have a playbook. We're actually writing the playbook as we go along. And we're not unique. This is happening across the nation, in every state, in all communities of this country, and certainly we know it's happening. This work is happening in Illinois. So I just want to close on this, that it's paramount with all the challenges, but with opportunities. We're very clear on one thing at the Illinois Hospital Association. If we continue to work together, providers, labor, community organizations, physicians, FQHCs, all the folks that care about healthcare delivery, if we continue to work together, and of course with our very good legislators and with this governor, we can actually take this opportunity and make something really meaningful happen in Illinois, across the country, in Chicago, downstate, in the suburbs, and everywhere in this state. And at the end of the day, if we work hard and we get those resources we need and we preserve the resources that we have today, we can make change real and meaningful for the patients, which at the end of the day is who we are all fighting for and who we all care about. So thank you very much.
Thank you. Next to his left, Ms. Luvia Quinones.
Thank you. Again, my name is Luvia Quinones, and I work at the Illinois Coalition for Immigrant and Refugee Rights. I'll be focusing a little bit in regards to why is the importance of the state exchange, and more specifically, why we as an organization, ICIR, are supporting it for the purposes of the immigrant and refugee community. There's a few slides in your packet, just to give you a quick overview of what I'll be discussing. There's a quick summary of who exactly in the U.S., when it comes to the states, have created either a partnership, ended up choosing the federally facilitated exchange, or the state-based exchange. I believe Jim went through this a little bit in the morning, but again, just in case there's somebody that is not too sure what's the difference between each of them, a quick summary of what exactly it means when we have each of those options. And here in Illinois, we have the partnership, and as we know, if we had the state exchange, we would actually be avoiding some of the issues that we're having, whether it be how you start out with the Get Covered Illinois website, and then that routes you over to the healthcare.gov, and I'll be focusing on some of the issues that have been affecting our community the last 4 or 5 weeks, when we've actually been able to enroll people through our in-person counselors. When it comes to what's the actual difference of having each of those different exchange options, just by looking at the top 2 or 3 states that have these different options, if you just look within the federally partnership, the federally facilitated exchanges, the top 3 states when it comes to enrollment as of December 1st are Florida, Pennsylvania, and Texas. When it comes to the top 2 for the partnership exchanges are Illinois and Michigan. For the state-based exchange, I listed the top 3, even though New York is doing pretty good, but unfortunately the data wasn't available as of December 1st. The one leading those efforts when it comes to completed applications is California, with about 250,000. As you could see, Illinois is doing overall good when it comes to the other partnership states, but obviously, as we all know, those of us in the room, especially those navigators and in-person counselors, that it could be going a lot better. I know not the perception, but the kind of the idea is when it comes to immigrants, are they actually eligible to buy insurance? Who actually is eligible? And I know one of the questions that was submitted was some rumors, I would call them, that undocumented are able to buy insurance with their ITIN numbers, which that is completely incorrect. They are not eligible to buy insurance, just the same way that because they're not eligible, they also will not get penalized. But I would like to clarify those adults that are undocumented and they do have children that are here legally, whether it be U.S. citizens or legal permanent residents, those undocumented parents do need to buy insurance for the children. So just a quick side note based on some of the questions. So focusing a little bit on when it comes to the immigrant and refugee population of who actually is uninsured and is it true that they don't qualify, I wanted to just give a quick overview there in one of the slides is there's over 180,000 immigrants that are uninsured and are eligible to buy insurance. So as you'll see from the chart, even though there is a large percentage that are undocumented, so therefore they're going to continue to be uninsured, there is a significant amount that do need to buy insurance, and those are the ones that continue to face issues in trying to buy insurance for multiple reasons. And that's what I'll be focusing on in the next few slides. When it comes to the immigrant and refugee population, very different from the rest, the big issue is the mixed status family. A lot of the times people think that undocumented, the whole family is undocumented. As you'll see with data that was recently published by Rob Harrell, the majority of undocumented, over 80% of them, and we're talking about a little bit over 600,000 individuals, they live in mixed status family, whether it be one person's undocumented, the other person is a native born, another relative is a U.S. naturalized citizen, legal permanent resident, et cetera. So therefore, within the same family, you're talking about very complex and different immigrant statuses that the system, whether it be the Get Covered Illinois or the healthcare.gov, they're not talking to each other, so therefore these people are just left in a limbo, wanting to buy insurance, but not being able to. One of the many reasons why we're advocating and supporting Campaign for Better Healthcare effort to create a state exchange. When it comes a little bit more for the mixed status family, one of the things that we were very surprised to see is just the concentration within the top 7 categories of mixed status families, whether it be those that are native born and legal permanent residents, as well as native born and undocumented. So again, this native born, so therefore if they already have the credit history as well as they were born here, they do not need to prove anything. But even that person that became a citizen, naturalized, is having issues right now buying insurance because the system doesn't recognize that they're now a U.S. citizen. Or because this person is a legal permanent resident, they don't have sufficient credit history in the country, so therefore they need to provide a lot more documentation than you or I, because we were born here and they weren't. So a lot of very unnecessary, burdensome documentation that not only was it not covered in the navigator training, nor in the in-person consular training, but it's also not, it could have been avoided by just creating the state exchange. To finish off, some of the things that I wanted to highlight besides the mixed status families being one of the crucial reasons for creating a state exchange and passing legislation, hopefully this coming session, is a couple of other the top 4 issues that we've been seeing when it comes to the enrollment within our in-person consulars that we're working with about 29 organizations. Not only the immigration status verification, both through the marketplace, but also through the APE system. Language access. For example, in California, that has a state-based exchange, they have their information in over 12 languages. Therefore, probably one of the many reasons why they have been able to complete over 250,000 applications. The complexity when it comes to the application process and who is eligible for what. When it comes to the immigrant community, there's a lot of different statuses besides undocumented, besides legal permanent residents, and besides naturalized citizens. You're talking about a bunch of different categories when it comes to visas. If you don't train these individuals, they have no idea what this visa is, and if you go to these different websites, doesn't explain them, doesn't tell them how it actually affects them. So again, versus if you had the state exchange, then we would be able to all work together, whether it be for the governing board to actually be representative of the community, as well as actually have the entity to push on some of these issues. And then lastly, the limited computer proficiency. When it comes to a lot of other programs, you always have that paper application process. When it comes to buying insurance, you're not able to. We keep on being told that should be the fourth resort. You should continue to use the website, continue to use the phone system. And if you do submit a paper application, there's no possible way to track it right now. So therefore, these individuals, when I'm talking about immigrants and refugees, not only are they already dealing with the complexity of it being a completely new system, new program, but then also having to requiring or needing, I should say, the in-person counselor, that individual assistance, because the system that has been put in place is not really working for them. So just to finalize, just wanted to give a quick overview of one of the many reasons why we as an organization will continue to support trying to pass a state-based exchange, as well as trying to make sure that everybody that is eligible does purchase insurance. Thank you.
Thank you very much, representing the labor community, Mr. Bill Luby.
Thank you. Can everybody hear me? Great. Thank you, Representative Davis. First of all, I want to thank the campaign for having me and having this panel and this important day of discussions around the ACA. And again, particularly, I want to thank Representative Davis for all his work on behalf of working families. I was glad to see you were moderating this panel. Been a great friend to labor. Leader Feigenholtz, her work, Senator Staines, Representative Gable. We work very closely with all of those great elected officials down in Springfield. And again, I just want to thank you, not just healthcare, but many, many issues that labor brings forward on behalf of working families. First off, I do want to say, if there are any hockey fans in the group, I want to say that if you're familiar with it at all, there's usually a guy that has to skate around and pester the other team and make them mad and throw them off their game. That's usually me with our organization, and sometimes you make your own team mad as well in doing your job, but I do want to say I'm not going to be that guy today. So I just want to make everyone aware of that. But I do want to say that the labor movement has been on the forefront of attempting to bring health care access to all for decades. We continue to work in that vein. We continue to work toward what we believe will be the solution, a single-payer system at the end of the road here. But the ACA, as it's currently written and passed, has presented some challenges to labor. Again, I'm not going to delve too deeply into the weeds on that. There are discussions on the federal level concerning these challenges, but I did, and Jim wanted me to talk a little bit about what some of those particular challenges are, and they are, some of them are documented and have been in the media as well, but multi-employer plans have faced significant challenges. Our construction industry in particular uses a lot of union-administered multi-employer plans. And also there's a significant challenge in terms of, and I've heard it brought up a few times, with part-time and full-time employment and major incentives for employers to, our concern is, and there's some movement in that direction now, to create a sort of subclass of workers that are under 30 hours a week. That, again, presents some serious challenges. We do believe in labor that the ACA has advanced the discussion, and definitely is a huge step toward what we need to get in this country, which is everybody health care. There's no doubt of that. Millions more will be covered now. It's created some definite parameters under which insurance companies will need to work under now. So there is plenty of good there, but again, I also want to reiterate that as with most major legislation that we pass in Springfield and in Washington, that there are fixes that need to be done to this act, and labor is going to push strenuously for them. But again, I want to thank everybody for having us today, and we do stand with you in terms of advancing the cause with whatever we need to do to make sure everybody has access to affordable health care in this country. Thank you.
Thank you very much. And our final panelist at the end there is Dr. Ram Krishnamurthy.
Thank you. Can everybody hear me? Thank you very much for inviting me. My name is Ram Krishnamurthy. I'm so grateful to be able to participate in this discussion, especially with such an amazing organization like the Campaign for Better Healthcare. I'm an internal medicine attending physician at the Hines Veterans Hospital. I'm also on faculty at the Loyola School of Medicine. I'm soon to be joining the University of Chicago. I care for veterans in very different settings in the hospital, including the primary care clinic, the emergency department, and the inpatient setting. But before this, previous to this, I was working in an academic medical center, and my primary care clinic was with Access to Care. Some of you might be familiar with this system. The Access to Care clinics generally provide care to uninsured and indigent populations. I provided primary care in Maywood, Illinois. And most of the patients that I saw were Spanish-speaking only women and other people of color, and people who would not have anywhere else to turn for their primary care for their chronic diseases. And I remember using a combination of my broken Spanish and hand-waving and pantomiming to try to communicate with these folks, and feeling just grossly inadequate in trying to provide care for these people, and feeling sad sometimes at how unequal this care was and how unequal the system was for these folks. But I remember very poignantly seeing how appreciative these women and other folks were for the care that they could receive. And we were always operating on a shoestring budget that keeps getting cut every year. And then I joined the Veterans Hospital as a full-time attending, and took care of a population of veterans who also are generally poor, have high rates of mental illness and substance abuse and chronic diseases, higher rates than the general population. And yet the VA in our country has decided that these folks have a right to access health care. And I was able to see also, I worked in many different settings in the VA, a well-coordinated system with a great electronic medical record that could talk to other providers, and also generally was able to provide access, again, to this, this chronic disease population. I worked for also, a fully taxpayer-funded government organization, and I've also seen the disadvantages of that, the bureaucracy and the federal red tape, et cetera. But what I noticed was that the delivery system that we had in the VA was that kind of coordinated system that has elements that we would like to achieve in our private system. So as a physician, from that perspective, I'm able to be an advocate. I want to, desire being an advocate to try to expand that access to more people. I'm also the Illinois director for an organization called Doctors for America. I hope many of you are familiar, but if you're not, we're a grassroots organization entirely run by about 15,000 physicians and medical students, everyone from early in their career to retirement and everything in between, from various different specialties. We're fully a nonprofit 501c3 organization that we don't endorse any political candidates or party. We started in 2008 when it became very clear that the president was dedicated to health reform, and we were excited about that. We grew out of a recognition that physicians needed a way to make their voice heard at the grassroots level. We wanted to be on the ground, even though we didn't have training in political activism or lobbying or health policy. We knew that we were automatically experts in the healthcare system because we saw that patients were suffering from it and that we were not able to provide the care that provided us professional satisfaction and fulfill our mission to them. Many of our professional societies were historically dedicated to advocating for the interests of our various professions, our specialties, et cetera. And we felt that many of these societies had failed in their recognition of the professional code of ethics towards social justice values that I think some of the nurses associations have actually adhered to. So we wanted to take direct action. So we wrote letters directly, we knocked on doors, we spoke to the media, we served on panels such as this one to advocate for a comprehensive health system reform that ensured equal access to all Americans for high-quality health care that was equally available to everyone. One of our most proud achievements was engaging in a bus tour for 2 weeks in late 2012, where we went from the Republican National Convention to the Democratic National Convention and visited community health clinics and communities and saw the people in southeastern United States, in North Carolina and Georgia, who could benefit from the Affordable Care Act. So we're supportive of the achievements that we've made, and we were excited, most importantly, for the enormous amount of work that we still have to do. Many of others, Jim and Brian Gorman, have already listed some of the achievements of the Affordable Care Act, especially in expanding Medicaid, creating a federal health exchange to bring more people into the system, if not everybody in, at least a giant leap forward. I want to list a few of the other achievements that we've made that are important to providers, and I think AJ also mentioned a few of these as well. You know, we have, I think, a set of insurance industry regulations that's also unprecedented, ensuring that providers and patients can provide preventive services free of copay, ensuring that women especially can get access to the preventive screenings for cervical cancer and breast mammography and wellness checks. It's codified in the law that now a wellness check that does not have to result in a fancy test or a medication prescription, that a wellness check can actually be reimbursed at a similar rate as other services, something that didn't happen before. We've shored up the Medicare Trust Fund to be solvent until late 2020s. We've invested in federally qualified health centers. We've tripled the number of National Health Service Corps providers to increase our primary care workforce in rural and other underserved areas. We've temporarily increased the primary care reimbursements for Medicaid, but that's a fight that we'll have to continue because there's so many hurdles and we have to make those changes more permanent. We've also built coalitions at unprecedented levels. Physicians in the American Medical Association, an organization that once infamously wanted to destroy Medicare, is now on board with one of the largest health reforms since the establishment of Medicare. The American College of Physicians, the College of Cardiologists, a number of organizations that represent over 500,000 doctors all over the country are on board with the Affordable Care Act. And one might ask the question, why this sea change? And I think the reason why, and I think AJ mentioned this as well, is we know that reform is coming whether we like it or not. Delivery system reform is already upon us. The hospitals in suburban Chicago and even inside Chicago are consolidating. The small and solo private practices are kind of going by the wayside. Payment for doctors and hospitals needs to be tied to value and coordination of care and services. We know that the adoption of much of the infrastructure that helps to coordinate care, like electronic medical records and other administrative services, are very, very expensive and are best achieved at a more of an institutional level instead of just a solo private practice level. Many physicians fear this consolidation. They fear losing reimbursement. They fear that bringing more patients into the system without enough primary care providers actually will see the system fail. They fear that accountable care organizations are going to do away with the solo practice. But I see, and our Doctors for America sees this actually as an opportunity. And I think we especially see that we have an opportunity to coordinate care for complex patients and actually improve what I think is all of our missions, which is improve health. We are all in this actually to prevent people from getting sick, not continue to take care of them when it's too late in the emergency room or in the hospital. We want to build coalitions, physicians and other providers, with other providers, not just see ourselves in a silo, but work with nurses, advanced practice nurses and physician assistants to see how we can build teams instead of getting into silly fights about scope of practice laws and licensing, et cetera. So we see this as a grand opportunity. Illinois has already done a great job of contracting with organizations to provide medical homes for our Medicaid population. And I think Medicaid and Medicare are two of the arenas where we can start figuring out and doing the research on how do we best keep people out of the hospital and keep people healthy, providing the wraparound social services that can also attend to the psychological and social illnesses that surround their medical care. So I see this as an opportunity, and so does Doctors for America. I want to close with just one story, just to give you an example of why Doctors for America cares about this. This is a story from Dr. Ian Burnett from Pennsylvania. Way back in 2009, he wrote this. I take care of many low-income women who are not able to afford contraception because their insurance does not cover it. I had a patient who was very dear to me die because of severe eclampsia for a pregnancy that she did not plan or desire. She became pregnant because of obstacles that the healthcare system put in front of her to getting contraception. Patients have a right to this life-saving treatment, and unfortunately, my patient was not able to benefit. If, with the Affordable Care Act and future reform, we can prevent 100,000 stories like this, then I think we've done a lot of good work, and we need to keep working hard to make sure that that's a reality. If you're a physician out in the audience, or if you know one, please let them know about Doctors for America and have them contact me. Our website is Doctors for America, DRS4America.org, DRSforamerica.org, and we'd love to have as many people join us as possible. Thank you again for having me.
All right, ladies and gentlemen, give all of our panelists a round of applause. So each one of you, probably, we could take of time and just go through each one of you in terms of what you said or what your comments reflected on. But let's just start here. I know I need to be mindful of time, Jim. So somebody can give me the high sign, or who should I? Oh, right there in the red. Thank you very much, ma'am. So let me start questions, and I have questions that were submitted via online, and I may change them a little bit, but we'll still try to get to the heart of what your initial question was. So access. So when you look out across this room, what you see are advocates, activists, providers, not-for-profit. You see all kind of the microcosm of folks that need to be, who are out getting people to engage and sign up and do all those great things. But there's still some trouble there. And even my own story is that I hosted a Affordable Care Act forum a few weeks ago in one of my suburban communities. The mayor of that community asked me to do it. And I said, well, we need to get the word out. So I produced no less than 2,000 flyers about the event and sent them home with kids at 2 middle schools who live in the community where we wanted to have the event. And I got 40 people to show up. 2,000 flyers, I got 40 people to show up. Now, we had, I think, 2 or 3 successes in terms of people actually enrolling, which we were happy about, but still, that much information, fewer people showed up. So we're still having that problem. So would each one of you like to kind of talk a little bit about how we need to increase that, what we can do, in each one of your sectors? What are you doing to maybe try to increase that flow and getting people informed and getting them signed up? We'll just start here.
Sure. And before I answer the question, I just want to thank Jim Duffett. As you all know in this room, Jim is a tireless advocate and brings just an amazing amount of passion to his work. And I know it's very genuine and mission-based, and thanks for all you do, Jim. I also want to just mention that in hospitals and in health systems, obviously we're much more than the acute care facility that we were, the hospitals where I was born, even the hospitals my children were born in. They're changing. We're really definitely evolving to a point where we're now giving services across the continuum, from prevention, we talked a lot about prevention, to primary care, of course, the facilities that the hospitals need to provide surgeries and other procedures, post-acute, and end of life, including home care, hospice, and palliative care. So we have a lot of touch points in our hospital community. We have a lot of touch points because we're providing those services across the continuum. And we need to continue to encourage our patients when they come to us. Many of them come to the emergency department. We all know in this room that that's most times the least valuable or the worst venue of care for patients to be seen. So we all need to, in the hospital community, we are committed to making sure that patients that come to us, whether they come to our primary care clinics or they come to our acute care centers or they come to our home health agencies, whatever their access point is to hospitals and to health systems, we want to make sure we get them enrolled. Point them in the direction for Medicaid, now with Medicaid expansion, get them information about the marketplace. And we are acting as navigators and as certified application counselors, and we will continue to do that as hospitals and health systems. But I think the other thing that's really important, and I'm glad to see the governor's office really getting out there, marketing the exchange, the marketplace, getcovered.illinois.gov. We need to make sure that so many of us, just think about it, there were 300 people in this room, and there are 200 hospitals in the state, and there are so many FQHCs and clinics across this state and across the country. Every one of us has to take a real responsibility and make it part of your mission, our mission, to make sure people get covered so that people can then have the access to health care.
Okay, so I think you mentioned maybe a couple of opportunities for those who are representing entities that are contracted to get out and do that outreach.
Yes, get out
spending
there.
some time in the emergency rooms, visiting FQHCs. You know, these are access points I think that are critical or could be critical in helping improve that enrollment. Ms. Quinones?
I would say for us, it's been focusing, not only in the usual places that immigrants frequent, whether it be the faith institutions as well as laundromats, et cetera, but also just spending a lot of time in translating information. As you guys know right now, the website Get Covered in Illinois only has information in English and Spanish, a little bit in Polish, but not in any other language. So having to focus on the Arabic language, Tagalog, Hindi, Urdu, et cetera, and making sure that that information is actually understandable, is actually at an educational level that people are actually going to understand. So I would say a little bit of just disseminating information in the person's language, and then also working with media outlets, whether it be radio, TV, et cetera, to try to kind of distill some of those fears that are out in the community, whether it be, is it true that if I provide my information and I'm undocumented, that immigration is going to come after me. So trying to make sure that there's trusted individuals in front of these uninsured to kind of dispel those fears.
Well, in terms of labor, from my earlier remarks, there are unions in different places on this. So there are unions that are working on getting the word out, and then some that are concentrating on getting the fixes into law that are they deem necessary, that won't be harmful to membership and those with collectively bargained health care.
I absolutely sympathize with the story that the representative said. We had Doctors for America has a campaign called Coverage is Good Medicine. We believe that getting covered is the first step in your health care. And I sympathize with your say. We had an event where we tried to get the word out as much as possible, ended up having a very, very small percentage of people. We're partnering with Enroll America, which is the spinoff from Ron Pollock's group. I think David Ellen is in the audience here. And we feel that physicians and medical students absolutely have a vantage point at which to talk about coverage. So this is not something that traditionally doctors have felt is their role. It's not something that even nurses used to fill their role, but now it's imperative. And the problem is that we also don't feel like we're very well trained to talk about it. So what DFA is doing is training medical students and physicians all over the country to talk about the Affordable Care Act, talk about coverage options, to avoid the politics, to dismantle the stupid myths that are out there, and because we have plenty of complexity that we have to deal with. I personally was able to train about a dozen or so medical students to go and talk at the primary care clinics that they rotate at during their medical school training. And often, medical students have a lot of time to be able to do that compared to physicians too. I hear some laughing over here. They have a lot of time and they take a lot of time, right, to do that. So we're working toward that because we know that people trust their doctor. They trust their healthcare provider. They trust nurses. They also trust their mother very much to help with their healthcare decisions as well, and we can kind of piggyback on that as well. So we believe that we have a role in getting the word out.
Thank you all very much. We have a few minutes left, and I want to ask you all to respond to one more question. I'm going to read the question the way it is on the paper, and you'll get it. It seems that some powerful Democrats in the House are lukewarm to the ACA overall. Is that the reason that Illinois does not have a state exchange? Is this a priority for the Quinn administration? Who wants to?
I'll go first. Thanks for having me. I need to leave. No. I don't think we want to engage in speculation, but I think what we do know is that the health insurance exchange or marketplace bill passed the Senate. And I know Jim Duffett worked very closely, as we did. Bill McAndrew from IHA is in the back of the room and was our point person on the marketplace bill with Senator Kaler and Representative Gable. And it passed the Senate, and it's in the House. And so we continue to advocate for a passage of a state-based exchange or marketplace, and we'll see where that goes, Representative Davis and Leader Feigenholtz, if you're still here. But what we do know is that some things we can't control. So and being good advocates, you continue to make your case. You continue to make it to leaders, you continue to make it to the rank and file, and you continue to build the case for why it is you're advocating for a specific issue. And I think we know that some of the states around the country some have had poor experiences, like Oregon, but some have had very positive experiences with a state-based exchange, like California, New York, even Kentucky. Kentucky has, I think, 11,000 enrolled in their state-based exchange, and they have 4 million people. We have almost 13 million people, and I think the number is somewhere around 7,000. That may be up because that was last week's news, but I don't think it's up much. So I think we can continue to look at how we build the case for having that closer control at the state level versus letting the feds run the exchange. Again, so long as, from the association's perspective, there are principles that are met that we have worked with Jim Duffett and the campaign and other stakeholders about. Who should fund this? The insurance industry is going to do well under this. We think they're the right parties, not those providers who have taken pretty extraordinary cuts over the last few years. We want to have a voice at the table through the governance, as Jim mentioned earlier in his remarks, and we also want to make sure that it preserves network adequacy. We've got to have an adequate network, and we can't have folks excluded from the opportunity to provide care in their communities. So I think that with regard to the governor, it was always my impression that the governor supported a state-based exchange. He also supported Medicaid expansion. And boy, there was a lot of activity between January and May 31st, as Jim knows, and as Representative, you certainly know, and as well as all the legislators, including Representative Robin Gable, who's just been another real strong ally and a great friend, and we appreciate her work. So what the governor has said is we want this to happen, but there were so many various priorities, including Medicaid expansion, which was very, very important, and thank goodness that got done. But we live to fight another day. And so the 2014 session starts at the end of January. That's only a month away, can you believe that? And we'll take this up again. We'll continue to work. I like that banner, we're all in this together. That's so important to all of the themes going throughout the morning. And we'll see where this takes us.
I'll just add a little bit more. I agree with everything that Mr. Wilhelmi was just saying. I think that everybody in the room, that's what the role is. I think as working towards social justice, working on behalf of the community, I think when it comes to this coming session, every time Jim or other people will be sending out emails when it comes to going down to Springfield for advocacy, for lobbying, et cetera, that's where you need to come to Springfield and talk about the importance of creating the state exchange. Yes, politics might still continue to get in the way, but the more that you actually talk to your legislators so they actually could hear the importance and some of the issues that we're having in Illinois with not having a state exchange and the difference it could make not only for those people that are having the issues, but how many more people could have insurance if we actually could create it.
I think Mr. Wilhelmi did a great job in answering that question. There are a lot of big stakeholders in it, and that takes a while. So, I mean, I don't know how different you can say it. That something doesn't happen quickly in Springfield when there are a lot of people with diverse interests at the table. I'll just leave it at that.
I don't have too much to add. I've learned everything I know about Illinois politics from Jim Duffett. So one thing I'll say is I think that network adequacy is extraordinarily important, of course, to providers, to individual physicians and hospitals. And if there's anything also that Harold Pollack talked about, it's that this common enemy of the insurance industry, I think, is common to both physicians, which is a very cynical way of looking at it. I think actually everyone, all these stakeholders do have an interest in a pragmatic approach to state insurance regulation to ensure adequate essential health benefits, but ensuring that network adequacy. Otherwise, we will continue to move divisively in fragmenting the healthcare system even more, where our newly expanded Medicaid recipients will be taking care of one group of providers, and the better, well-paying groups are taking care of another providers, and that system can't survive. So there is a lot of interest among these stakeholders. We don't actually need to be enemies, and there is important coalitions that we can build here.
Thank you all very much. So in your best, I'm going to ask you for a one-word answer as we close. So will we fare better with a state-based exchange, Dr. Krishnamurthy?
Yes.
Mr. Luby?
Yes.
Yes. Okay. Ms. Quinones?
Yes.
Mr. Wilhelmi?
Yes, with those principles that I mentioned, yes.
Fantastic. Ladies and gentlemen, please give our state panel a round of applause.
Good job.
I think Jim's going to come back up. And just in closing again, let me thank Jim Duffett, the Campaign for Better Healthcare, for all of their hard work. Please give yourselves a fantastic round of applause. Advocacy is a very important thing, ladies and gentlemen. So if I asked you this question as Jim makes his way up, can you say with 100% certainty that you know who your state representative is? Based on where you are registered to vote, do you know who your state representative is? Well, if you know who your state representative, that's the first call you need to make. When you leave here as an individual, not representing your organizations in terms of how you feel about this overall, but as an individual, if you believe in this, you believe in the direction that this needs to go, that should be your first call. As we go back to Springfield at the end of January, every representative should have received at least one call from a constituent saying, we need to pass a state-based exchange here in the state of Illinois. So if you could do that for me, I would really appreciate it. Thank you all very much. Have a fantastic day.
So, quick summation. So what did we learn here today? We heard the statistics and reasons that led to the ACA. But let's remember what Harold Pollack said. The ACA is the foundation. We have begun to build on that foundation by working to enroll community members in healthcare. But the work has just begun. We need to remember that we are in this together. As a result, together, we must continue to inform, implement, and improve. It is the Campaign for Better Healthcare that will continue working for and with you to accomplish these goals. As Jennifer Leone said and pointed out, there are many ways that you can be involved with the campaign. So please, again, read through the literature in your packet, find the way that best suits you individually or your organization, and participate. You have to be an active participant in order for the ACA to reach its full potential. And each year, I ask each of you, and I kind of challenge each of you to go out there and to speak to family members, to friends, to relatives, to neighbors, but speak to strangers too. You hear people talking about the enrollment process in the ACA, at least I do, almost everywhere you go. I speak to a lot of strangers almost every day that I'm out and about. If I hear people talking about the ACA, about they're trying to enroll or, what experiences they have, I stop. I ask them, can I join your conversation? Can I talk to you a little bit about that? We need to inform, we need to encourage, and we need to keep enrolling. We need to dispel the myths. And we need to encourage, because as President Theodore Roosevelt said, we are face to face with our destiny, and we must meet it with a high and resolute courage. For us, it is the life of action, of strenuous performance, of duty. Let us live in the harness, striving mightily. Let us rather run the risk of wearing out instead of rusting out. We cannot afford to rust out until everybody is and nobody is. Thank you. Have a great afternoon.